Hello and welcome. You're listening to the Sickle Cell Action Network, a weekly internet radio show presented by Martin Center Sickle Cell Initiative and sponsored by Mass Therapeutics. We're coming to you live from Indianapolis, Indiana, and we're here to serve you by providing up-to-date information and opinion on all matters pertaining to sickle cell disease. My name is Gary A. Gibson, and I am your host for the next 2 hours. Let me start by saying that I don't have sickle cell disease, nor do I carry the sickle cell trait. In spite of that, I am no stranger to sickle cell. Quite the contrary. You see, even though I don't have sickle cell, it has had a very huge impact on my life. That's true because its complications took my wife from me after 12 years of marriage. It also caused her to have a miscarriage that resulted in the loss of our twin babies that she was carrying while in a sickle cell crisis. So all told, sickle cell has taken 3 lives from me, and I feel the pain of those losses every single day. I currently serve as the president and CEO of Martin Center Sickle Cell Initiative, a community-based organization that has been serving people with sickle cell for over 45 years. Each day I attempt to transform the pain of my losses into positive energy that is focused on making a difference for those who are battling sickle cell. From being involved with sickle cell for over 40 years, I'm able to say that much progress has been made, but there is still so much work to do. This show is an opportunity to contribute to the ever-expanding dialogue about sickle cell that is taking place all around the world. Our show is about raising awareness, but it is also about so much more. I like to say that sickle cell awareness is important, but we need more than awareness. Those living with sickle cell are already aware. That makes me ask, so what are we doing for them? My answer is, not enough. That's why we've named this show the Sickle Cell Action Network, because awareness without action has very little impact. We want this show to be a source of information and a call to action to help those who must live with sickle cell in their midst. We have designed the show to provide information that is beneficial to patients, caregivers, family members, and friends alike. Most importantly, we want people with sickle cell to know and understand that they are not alone. The Sickle Cell Action Network show features live guests who are healthcare providers, patients, advocates, and others who are engaged in the fight to eradicate sickle cell and ease its burden on those it affects. Today we are honored to have a special guest speak with us about sickle cell care. Joining me in studio today is Dr. Ann Greist, a hematologist at the Indiana Hemophilia and Thrombosis Center. We're very happy to have Dr. Greist with us today. Before we get to today's topic, however, I want to share some of our upcoming topics with you so that you'll know what we're going to be doing. In future weeks, we will cover such topics as the Sick Cells documentary project, sickle cell research update, traveling with sickle cell, connecting the sickle cell community, and many, many others. So as you can see, we are serious about sharing information, and we hope that you will join us every week, same time, same station. If you've missed some of our previous editions or wish that you could listen to them again, don't worry. Just go to the Martin Center Sickle Cell Initiative YouTube page and you'll find them there. Now, let's get on with our show, and we'll start with this week's edition of Sickle Cell News Update. We've selected a few different stories for you today, and the first one I'm going to share with you is another story of hope, and this one relates to a woman whose sickle cell disease has apparently been cured by transplant. This story comes to us from Temple College, and it reads as follows. While Ethel Flowers cares deeply about her daughters, Tanisha Flowers and Deidre Flowers Williams, and is thrilled at the successful outcome of the stem cell transplant that appears to have cured Deidre's sickle cell, she's always a teacher. Flowers, vocational nursing instructor at Temple College, views her daughter's most recent journey in healthcare as a teaching moment. They are part of nursing history, Flowers said of her students. Deidre Flowers Williams was number 43 in a National Institutes of Health clinical trial that is studying the use of sickle cell transplants to cure sickle cell disease in adults. Number 1's transplant took place 11 years ago, and that person is alive and sickle cell free, according to Flowers. Even though my daughter's transplant is still in the trial phase, when it becomes protocol for sickle cell anemia treatment, my students can say we were in school when our instructor's daughter was part of that trial, Flowers said. These nurses will be able to practice that protocol. This is what NIH does, she says. They perform the studies, including all of the phases, and then set protocol for all medical facilities to follow. Flowers Williams was lucky her sister Tanisha Flowers was a 100% match, which meant the chemotherapy and radiation she would receive prior to the stem cell transplant could be less aggressive. The sisters met with an NIH team in Bethesda, Maryland in October to determine if they would be selected to be part of the trial. They hadn't gotten off the plane when returning home when Flowers Williams got the message that she had been accepted into the study. The sisters returned to Maryland to begin the process. Both were checked from head to toe to determine if any unrelated health issue could affect the transplant. Tanisha Flowers was given drugs to increase her stem cell production, which were then harvested. Deidre began the chemotherapy and radiation treatments to suppress her immune system so her body wouldn't reject her sister's stem cells. The transplant took place on November 19th. They refer to it as a rebirth, Flowers said. They start counting the day after the transplant through 100, monitoring her stem cell counts. At 4 weeks, 30% of the circulating stem cells in Deidre were her sister's, higher than what is usually present. She was ahead of the benchmarks the entire time, but she had to stay the 100 days for the study and documentation, Flowers said. Deidre arrived home February 26, 2 months early. Tanisha was able to return home after 2 weeks. All things considered, the sisters did well throughout the process, but it wasn't a cakewalk. Deidre got a rash from one of the medications. Tanisha told me that when Dee Dee first started receiving the chemotherapy, she had a reaction, Ethel Flowers said. She said, "Mom, it was like something from Poltergeist. She was coming off the bed." Flowers was told her family was glad she wasn't present. "If you had been there, you probably would have said, 'Stop, you're hurting my baby,'" Tanisha told her mother. Adjustments were made to the pain medications to deal with the problem. The problems for the donors are many and can be cost prohibitive, Flowers said. Excuse me, especially if their employers don't approve the time off even with no pay. "I would like to see some legislation like the Family and Medical Leave Act to protect the donors and their jobs. Associations that advocate for various illnesses and diseases could make donor assistance part of their mission," she said. Before the transplant, Flowers Williams could barely make the walk from her bedroom to the bathroom. Now she's walking more than 3 miles a day. There were some who considered the transplant too dangerous, but Deidre didn't fear death, her mother said. She already felt like she was dying. So a good story coming out of Temple College for a transplant that was done with a part on behalf of the National Institutes of Health in their clinical trials for stem cell transplants, and we hope that this continues down a good path. The next story I want to share with you is a heartbreaking story, and this is actually written by the Miami Herald editorial board. And it goes as follows. The heartbroken families of relatives who died under suspicious circumstances behind bars in Florida's prisons have every reason to ask, will the stonewalling ever end? One more family, one of too many, has been pushed down the rabbit hole, searching for answers about their loved one's death, possibly a result of official neglect, indifference, or violence. It's yet another account of governmental entities doing more to obscure than shed light on what's still amiss in Florida's prisons, in spite of some improvements since Corrections Secretary Julie Jones has come on board. But what looks like cover-ups continue, and if elected officials and state bureaucrats allow them to go unaddressed, then they too are culpable. As reported by Herald writer Julie K. Brown, in several letters, Michael Baker, now the late Michael Baker, begged for relatives' help. An inmate at Santa Rosa Correctional Institution in the Panhandle, Baker said he had been beaten and his teeth kicked out, and that corrections officials doused him in chemicals because he alleged he filed complaints against them. In addition, Baker had sickle cell disease. According to his sister, he told her in several tearful phone conversations that nurses were withholding his medication. "It's just heartbreaking," said Baker's attorney, James V. Cook. "I have a series of 5 or 6 letters in which, in letter after letter, he tells me the nurses are making fun of him, they are telling him to go ahead and just die." And that's what Baker did on March 10th in a private hospital after his excruciating pain allegedly had been ignored too long. This is a terrible story. It comes on the heels of other issues in the Florida correctional system, and we certainly do not like to hear of people with sickle cell disease being mistreated or having their medication withheld. Another story comes from Waco, Texas, and this one says, Sickle Cell Weekend. The Central Texas Sickle Cell Anemia Association is having a Sickle Cell Weekend fundraising event Saturday through Monday. Events will include the Sickle Cell Anemia Radiothon from 6 a.m. to 6 p.m. Saturday on radio station 94.5 The Beat. On Sunday, churches are encouraged to take a love offering to support the association. Offerings can be mailed to the Sickle Cell P.O. Box 881, Waco, Texas 76703. And then on Monday, Sickle Cell Spirit Night will happen from 5 to 7 p.m. At the Chick-fil-A at 901 South 7th Street. And customers need to mention the Sickle Cell fundraiser for the association to receive the donation. It's great that somebody has put together a fundraiser that spreads through the whole weekend. Looking forward to that. Our last story today is coming to us from India. We refer to a lot of stories from time to time about India because we want people to ensure that they know that there is a lot of sickle cell in India. So this headline says, Mangalore bus employees collect money for college girl. Drivers, conductors, and cleaners of Udupi city buses collected 150,000 rupees. Sounds like a lot of money, but in U.S. terms, it's $2,257. And they presented it to Geeta, a 19-year-old girl who was suffering from sickle cell anemia. The amount was presented to her at a function held at a city bus stand in the presence of the superintendent of police. The bus drivers and conductors kept collection boxes in the city buses and at the city bus stand and collected the amount. Sidhar Palan, Hanif, and Santush Kumar, city bus employees, played an important role in organizing their colleagues. When we learned that Miss Geeta is suffering from sickle cell anemia and that her college mates and some organizations are contributing for her treatment, we thought that we too should collect as much money as possible and help her, he said. So Mr. Anamali said that the bus drivers and conductors had sent a positive message to the society through their exemplary conduct of helping a person in need. This gesture would help Miss Geeta, he added. We're always happy to hear that there are people that care enough to take up some collections and do something to help people that live with sickle cell disease. That's our last story for today with the Sickle Cell News Update. We're going to take a break, and when we come back, we'll return and start speaking to the awesome Dr. Ann Greist.
Hi, I'm Gary A. Gibson, your host for the Sickle Cell Action Network Internet Radio Show. If you are impacted by sickle cell disease in any way, whether you are a patient, a caregiver, or a friend, you need to join me every Tuesday at 4 p.m. Eastern Time. I promise that you will find our show to be full of information, perspective, and opinion about all things sickle cell. See you Tuesday right here on RadioNets.tv, the Cool Groove site.
Welcome back to the Sickle Cell Action Network. I am Gary A. Gibson, your host, and it is Tuesday, April 5th. I can't believe it's April 5th already. With me today is a very distinguished Dr. Ann Greist, who practices in hospitals and at the Indiana Hemophilia and Thrombosis Center. Dr. Greist is a hematologist, oncologist, trained physician, and I'm just so thrilled to have her on the show today. Welcome to Sickle Cell Action Network show, Dr. Greist.
Thank you very much. I'm very happy to be here.
Great. I'm going to start by saying that I've spoken with several of your patients over the last few years, and each of them love you. One of the reasons they say they love you is that, one, you know what you're doing, and two, you're very kind. I'd like to say thank you on their behalf for taking care of them, the ones that have spoken to me, as well as all of the others that you've taken care of that I haven't spoken to. But apparently you're doing something right, and that's one of the reasons we wanted to have you on the show. Thank you for what you do.
I really appreciate that. Those are very kind comments.
Yeah.
It's certainly a privilege to take care of our patients with sickle cell. They've taught me a great deal over the years.
Oh, I bet. Would you please tell us a little bit about yourself? Where were you born? Where did you obtain your medical training? How long have you been practicing? And have you always treated people with sickle cell disease?
Well, as you can probably tell if I say a few more words, I didn't grow up in Indiana. I was born in South London in England, and I went to medical school in London. I went to King's College, which is one of the teaching hospitals, one of the big teaching hospitals in London. Actually, they have a very active sickle cell program there, and quite a few people in that part of London originally came from the West Indies. But when I was a medical student, I really was not didn't have a great deal of contact with the sickle cell program, but I do remember some teaching from the hematologists there and seeing some patients. So that was probably my first exposure to sickle cell disease. Then I, in the 1970s, I met my husband when he was a senior medical student at Indiana University. And he had come to London to study for a couple of months. So
you met your husband in London?
I met my husband. I met my husband in London. It's a funny story. It turns out I found out he was very interested in speaking French, and I love trying to speak French. So that was the common interest that we had and how we got to know each other. But eventually, we both finished medical school. He went to South Bend, Indiana, to do a family practice residency. And during that time, we kept corresponding, and we ended up spending enough time together that we got married. And I arrived in Indiana, fresh out of medical training from the UK. And some of the physicians in the South Bend family practice program helped me get into Indiana University as an internal medicine intern and resident. And so I often tell people I sort of grew up at Indiana University. And at the end of the residency, I discovered I was very interested in oncology and signed up for an oncology fellowship. But that then led into hematology and oncology because the two areas are so closely intertwined.
Wow. So you come to us from London, and you mentioned that there is a sickle cell program there at the hospital, and you know, I often want to try to remind people that most people don't think that sickle cell is in other places. You know, their understanding is somewhat limited sometimes, but recently saw some data that showed there's as much as 20,000 patients in England, in UK, with sickle cell disease. And that's not something I think your average person is going to think about. So you started out, you were in South Bend, which I spent time in South Bend too. I went to the University of Notre Dame there, so I'm quite familiar with South Bend, and glad to know that we have that in common. We spent time there together. How did you become a hematologist working on sickle cell?
I think to explain that, first of all, it would help if I just give a little bit of background to the field of hematology.
Please go ahead.
So at the time I really started working with sickle cell disease, I was a full-time faculty member at Indiana University Medical Center, where I do still have the privilege of working one day a week. But in an academic program, typically the faculty physicians tend to specialize either in oncology, which means cancers such as breast cancer, colon cancer, lung cancer, what we call the solid tumors, or hematology. And hematology can be really divided into cancerous hematological conditions like leukemias or cancers of lymph glands, and other types of blood and bone marrow cancer. But then there's also an area that's referred to, sometimes it's referred to as benign hematology, meaning not cancerous. I think we tend to prefer to refer to it now as non-malignant hematology, which means blood disorders that affect the blood cells and the bone marrow and the lymph system, but are not directly cancerous. So I became interested in that particular area of hematology. And that led me to contact with patients who are coming into our hematology clinics with sickle cell anemia as one of the disorders that is covered under that umbrella.
Right. Okay. Wow. Do you still treat patients with conditions other than sickle cell?
Yes, I do.
Okay, and what is that?
One of the other disorders that I've specialized in over the last 25 years or so has been hemophilia and other bleeding disorders. So those are disorders where individuals who are affected tend to have problems with bleeding. Their blood doesn't clot properly. And the reverse of that is people who have thrombosis, where their blood may clot more than is needed, and they can have unwanted blood clotting. And all of these different groups, the hemophilia, the thrombosis, which is where the name of our practice comes from, and sickle cell, they often share the characteristics of being lifelong disorders, things that can be passed from a parent to a child. So you often find that there are several members of the same family that are affected by the disorder, and they are often conditions where multiple disciplines within the area of hematology need to come together to provide the best possible care for those who are affected.
Okay. Each of those disorders are bad. I mean, they're terrible, and they cause problems. Are they as is hemophilia and thrombosis, are they as well understood as sickle cell is, in your mind?
I think the answer to that is probably yes and no.
Okay. Could you explain?
For example, thrombosis or blood clotting is extremely common. It's probably it's the number of people affected by blood clots in the United States, for instance, is probably much higher than the number of people affected by hemophilia or sickle cell disease. And there are certainly people who have blood clotting disorders that are genetic. And are passed from parent to child. But there are also many, many situations where people may develop blood clots as a complication of another medical condition. And unwanted blood clotting is probably the most common complication that can affect anybody who's admitted to the hospital for any reason whatsoever. In the 1990s, quite a bit of progress was made in the understanding of genetic blood clotting disorders, but since that time, there haven't been any major breakthroughs. So I think there is a lot about thrombosis, blood clotting, that really remains to be understood.
Ladies and gentlemen, we're speaking with Dr. Ann Greist, a wealth of information as it relates to blood disorders. We're going to take a break, and when we return, we'll continue our discussion, and I bet and I promise you'll learn even more. This is the Sickle Cell Action Network Internet Radio Show on RadioNext.tv, the Cool Groove site, and we'll be back. And we are speaking with Dr. Ann Greist, who is a practicing hematologist, oncologist at the Indiana Hemophilia and Thrombosis Center. During the break, Dr. Greist mentioned that, interestingly enough, people with sickle cell disease can have thrombosis issues. And I said, well, why don't we touch on that when we come back from the break? So let's do that, Dr. Greist. You said that, so explain.
I think one of the things we were anticipating that we might discuss on the show today was the sort of complications that can occur in an adult with sickle cell. And I think in addition to awareness about the sort of symptoms that someone with sickle cell can commonly experience, we need to continue to provide education to our adult patients,
Right.
because the field is evolving, and I think sometimes we learn things about sickle cell as we go along, things that we didn't necessarily
Right.
even ourselves realize could be complications of sickle cell disease. And I think probably over the past decade there's been realization that DVT, or deep vein thrombosis, that sort of blood clotting, is a potential complication more for an adult with sickle cell than for children.
Okay.
But that this is something that we need to be aware of. We know that the red blood cells in a person with sickle cell disease can block up the tiny little blood vessels in the tissues, but DVT is a situation where a large vein may be blocked by a blood clot that we call a thrombosis.
Okay.
And that's because the physical stress of sickle cell disease is enough to cause unwanted activity of the blood clotting system as a natural response. And then there are other things that can promote this unwanted blood clotting in an adult with sickle cell disease. So a young adult woman with sickle cell disease, for instance, who is taking some type of hormone birth control,
Okay.
that's something that can contribute to blood clotting, or pregnancy, or the aftermath of a
Okay.
pregnancy.
Okay.
Being very ill in the hospital and confined to bed, that's another thing that can promote unwanted blood clotting
Okay.
in sickle cell. And so one of the things we started doing for our adult patients when they're admitted to the hospital with an acute sickle cell complication is we actually prescribe a low-dose anticoagulant or blood thinner that they receive on a daily basis
Okay.
to prevent a blood clot from occurring as a complication of that hospitalization. And the most common way we do that is actually to provide a medication that's called enoxaparin. This is an injectable anticoagulant, and it's just given once a day as a small subcutaneous injection by the nurses, and that's actually part of our typical inpatient protocol for someone admitted to the hospital with, say, a pain crisis of sickle cell.
Wow. Okay. That is very informative. Thank you for that. From the perspective of an experienced provider, how would you characterize sickle cell disease?
I've often talked about this when I've given lectures either to healthcare professionals or talks to individuals with sickle cell, maybe family members. And it never ceases to amaze me that this one change in the DNA can cause an illness that affects or has the potential to affect every organ in the body, and it's a lifelong burden that someone affected has to carry with them. They may be something that affects them every day. It may be completely disruptive. And the other amazing thing about it is the fact that it can vary so much in its behavior from one person
Right.
to another, even though they may have exactly the same
Right.
DNA change in the hemoglobin molecule.
And we're going to talk about that a little bit. So, if I'm correct, you do primarily care for adults. Is that true?
That is correct,
And
yes.
and if so, what are the age ranges of the people that you treat?
We sort of define adulthood in the medical field often as being 18 years and up.
Okay. Do you know how old your oldest patient is?
I think I have a patient right now who is in their early 70s.
Okay, great. And so about how many sickle cell patients are you caring for these days?
Roughly a little over 100, about 120 or 130 I think we have on our registry.
Okay. And Dr. Greist, what are the top 3 issues that you find in treating people with sickle cell?
Well, I certainly think that addressing the painful complications of sickle cell disease and management of those painful issues may not necessarily be the top issue, but it often, but not always, figures quite prominently in the care of somebody with sickle cell.
Mm-hmm.
I think also the fact that sickle cell disease may affect any organ of the body is another top issue,
Mm-hmm.
Because it means we have to be on our toes as healthcare providers, because a person with sickle cell disease could have a variety of different complications,
Right.
and could have a whole variety of different symptoms.
Okay.
And I think the third issue would be the impact that the sickle cell has on the life of someone affected, the lives of all those for whom we care, from not just a physical but a mental and spiritual
Mm-hmm.
standpoint as well.
Okay. I would concur with you as well. So we kind of touched on this a moment ago. Let's come back to it now. That sickle cell is a very complex disorder, and partly because it can affect and does affect patients in so many different ways. Would you talk a little bit about how sickle cell affects each patient differently, and how it's got to be difficult, but how do you manage their care when it presents itself in so many different ways from patient to patient?
When we talk about the individual variability in the manifestations of sickle cell from one person to another, there are things that come to the mind of a healthcare provider right away. And one of the differences from one patient to another, even if they have the same type of sickle cell, might be the frequency with which they need to come to the hospital, particularly for management of what we refer to as an acute painful crisis, an acute painful episode. Healthcare providers often refer to it as a vaso-occlusive episode, meaning that the person or the patient with sickle cell is having severe pain, usually in bones, muscles, and joints, and that pain is something that reaches a height where they have to come to the hospital for assistance.
Mm-hmm.
So we see variability in the level of severity of the pain that people experience, the frequency of these painful episodes, and perhaps the frequency with which people need to be admitted to the hospital for management over time.
Mm-hmm.
So there are some people who are quite severely affected by these sorts of symptoms, and it's really a struggle sometimes just to keep their pain managed effectively so that they're even able to stay out of the hospital. On the other hand, there are other patients, again, who may have the same type of sickle cell. Perhaps we only see them a couple of times a year, and there are occasional patients who have very prolonged periods of time in between these painful episodes, or hardly ever have a painful episode. And we can't always explain with great clarity why it is that, even to ourselves, why it is that one person is so severely affected and someone else is not. Now, that person without frequent painful episodes may be having other complications of their sickle cell.
Right.
So that they're not necessarily healthy or experiencing no limitations from their sickle cell by any means, but they may be different manifestations.
Okay. Your colleague, Dr. Emily Meyer, was on our very first show, and she, of course, did a wonderful job, just like you're doing now. But I think one of the things that she mentioned, I asked her this very similar question to the one you just answered, and one of the things that she said that makes it difficult for her as a pediatrician is to be able to provide the family with an idea of what the patient might expect with regards to complications. And so, in other words, because sickle cell does affect each patient so differently and can do that it's very difficult to say to a mother and father, well, by the time the baby is 5 years old, they're going to be experiencing all of these things, because they might and they might not, based on the variability of sickle cell. Is that similar as people age? Does it still become, or is it still difficult to try to predict what those patients might go through when you're looking at them even individually? You know what I mean? So if you're looking at patient A and you know patient A's history and you've been treating patient A for about 5 years or something like that, is it still difficult for you to be able to say, well, in another 5 years you might be wanting to be sure this is taken care of?
I think it's probably a little easier for us adult docs.
That's what I would think, but I wanted to be sure.
Yes, because by the time someone has reached adulthood, I think that we have a lot of information about the pattern of their disease and the sort of problems that they've had growing up, and so I think that makes it a lot easier for us as providers for the adult population. I think by that time it's become much clearer what is the pattern of their sickle cell and what they're dealing with. To a large extent, that's not so much of a mystery by that time.
Okay, that's kind of what I thought, but I just needed you to verify that for me. So one of the things that many people know little about is that sickle cell can and does affect every part of the body, and we touched on that, but I would like to go a little deeper if you could. So would you take a few minutes to explain that? I mean, why and how does sickle cell cause so much damage to so many different parts of the human body?
Well, I'll do my best.
Do your best.
That's a big question.
That's all we want.
I think many people know that the core of the problem with sickle cell disease is the abnormality of the red blood cells, and the fact that red blood cells in sickle cell have lost the ability to flow smoothly and easily through the circulation and deliver oxygen efficiently to the various tissues. But in recent years, we've learnt more and more as physicians about other blood cells, particularly white blood cells that help to fight infections and inflammation, and platelets, which are little cells that help to form blood clots. It turns out that probably all those blood cells are involved in the process whereby sickling occurs, and the tissues are deprived of their supply of oxygen and other nutrients.
Okay, so hold on, and I'll let you continue, but the platelets, like, what role do they play?
Well, platelets in the normal circulation clump together when a blood vessel is injured and will plug up the hole that's created in a blood vessel by an injury.
Right. And
then other chemicals in the bloodstream will help to solidify around the platelets and hold them in place and make a neat little blood clot.
Okay.
The chemical changes in the bloodstream that are occurring because of these abnormal red blood cells kind of entrap the white blood cells and the platelets in this reaction, and there are a host of other chemicals that come from the platelets, the white blood cells themselves, cells in the inside lining of the blood vessels, that all contribute to this phenomenon where the little blood vessels are blocked and the nutrients and oxygen just can't get through. So there are things that are different from one individual to another individual that we think probably help to modify how this affects one person compared with another person.
Okay.
So it's no longer just a question of they've got sickle cell red blood cells, and the sickle cell red blood cells have this one change in their structure that causes them to be sickle cells. It's the way their white blood cells react to this, the way their platelets react to this, the way other inflammatory chemicals that are being produced in the lining of the blood vessels, all of these things reacting together. So there are subtle differences in the circulation between individuals that probably result in the different signs and symptoms that one sickle cell patient has compared with another.
I think that's very, very informative, and I hope our listeners agree with me. That is very well explained very well. And we always see these pictures or graphic depictions of sickled cells blocking a blood vessel, and it's pretty classic where you have the sickled cells blocking, but you're saying there's a lot more involved. It's not just those sickled cells that's involved in this problem.
Absolutely.
Yeah, okay, and that's really good, because I think maybe a lot of people don't understand that.
A lot of doctors don't necessarily. Well, I'm having a struggle with it myself.
Are you really? Okay. Well, that's fascinating, and it is time for us to take a break, and when we come back, we'll continue learning from Dr. Ann Greist. This is the Sickle Cell Action Network on the RadioNext.TV Cool Groove site. The Sickle Cell Action Network show is sponsored by Mast Therapeutics, a publicly traded biopharmaceutical company headquartered in San Diego, California. Mast is currently leveraging the molecular adhesion and sealant technology platform derived from over 2 decades of clinical, non-clinical, and manufacturing experience with purified and non-purified polaximers. Mast has developed a drug called MST-188 as a candidate for serious or life-threatening diseases with significant unmet needs. Among those needs is the treatment of sickle cell disease. Mast has enrolled sickle cell patients in a clinical trial known as EPIC. EPIC stands for Evaluation of Purified Polaximer in Crisis. If successful, EPIC could result in the first treatment of its kind to treat sickle cell disease patients while they are in crisis. The EPIC study aims to determine whether MST-188 can shorten the duration of a painful crisis. MST-188 is an investigational drug that has not been approved for commercial sale in any jurisdiction for any use. MST-188 potentially improves oxygen delivery, and it may help keep blood vessels from becoming blocked and more obstructed. It may improve blood flow by stopping cells from grouping together. It may also reduce inflammation, and it may restore cell membranes and give damaged cells time to heal. EPIC participants continue to receive their normal pain treatments during crisis, and their participation is free of charge to them. The patients involved in the EPIC study may not only be helping themselves, but they might also be helping future generations of those yet to be born. If you're interested in learning more about the EPIC study, please visit www.theepicstudy.com. We are speaking with Dr. Ann Greist, who treats over 130 or so adult sickle cell patients. She's been doing it for over 2 decades. She knows what she's doing, and she's shedding a lot of light on things that we talk a little bit about, but she's giving us more information, and we're very appreciative of that. And we're going to continue the discussion to see if we can draw some comparisons between pediatric care and adult care. So, Dr. Greist, we have had your colleague, Dr. Meyer. We've also had Dr. Monica Corona of Raleigh Hospital for Children on our show in the past. They're both pediatric hematologists. And from your perspective, what are the key differences in treating children and adult sickle cell patients?
I think I can probably best try and divide this into a couple of different categories.
Okay.
And maybe talk about the physical complications, where there are differences between children and adults.
Okay.
And then perhaps some of the other psychological and social issues that adults deal with that I think are different from what perhaps our pediatricians are up against.
Okay.
So I think from the physical standpoint, there are some the pediatricians I think focus quite a bit on certain preventative measures. One area in sickle cell that's extremely important for them is stroke prevention and care of children who have had a stroke as well. So transfusion therapy has been at the forefront of that sort of care, and so there's quite a lot of focus on that in pediatrics.
And reliance on transcranial Dopplers and things like that too. Okay.
So in the adult field, as we were talking before, really, when it's difficult for the pediatricians to tell parents what to expect or what they might need to face, how they might need to care for their children, that's definitely one of the areas where by the time they reach adult life, that's probably a good example of where we aren't so much guessing, because we know by the time somebody's reached adult life, were they as children someone who did have an abnormal transcranial Doppler, or were they in fact children who did suffer stroke? And so we know at the point at which they transition over to the adult service whether that's something that we really need to be
if that's in their history.
Yes, that we really need to be mindful of. Perhaps the biggest difference in physical terms between the pediatric and the adults is that as adults we really begin to see the accumulation of the effects of sickle cell that have occurred up to the age of 18 and well beyond. And so we, even as young adults, our patients may have lost a little bit of the physical resilience that they had as children. And so that means that their care could be a bit more complicated, because if they are admitted to the hospital, we really need to be watching things very closely, like their kidney function.
Okay.
So we may need to be a bit careful about certain medications that we avoid. And also, I think we may find that for various reasons our adult patients perhaps have not previously been on hydroxyurea, and so we may actually identify some potential for tissue damage or frequent vaso-occlusive episodes, and start to talk to them more about really beginning to take hydroxyurea, whereas perhaps that wasn't such an issue for them as children. On the other hand, I think adults with sickle cell are not just confronted by their health issues. They may be trying to work. They are certainly trying to manage their own health care. They might have other family responsibilities as adults in addition to their own. We certainly have young adults with sickle cell who have their own young children. And so they may be struggling not only to maintain their own health but to support a family. And so that brings with it a whole train of stressors that can play into their sickle cell. And I think perhaps, without having discussed this with my pediatric colleagues, I think perhaps sometimes adults with sickle cell begin to be more fearful about what their life expectancy might be, especially if they've been through serious complications of their sickle cell, and if they know anybody with sickle cell of their own age who's had a life-threatening complication, or perhaps even died from their sickle cell, or somebody in their family, that can. I know I've had patients with sickle cell in their 20s and 30s who've really been afraid that they're not going to live much longer.
Right. And that we've talked about in previous shows, and we'll probably talk about it some more, because it's a big part of living with sickle cell, is that it's public information. Sometimes the doctors, the young pediatricians that don't have a lot of experience, maybe share that when somebody's young and say, I don't think you're going to live to be 20, or things like that. We've got a lot of patients that we've talked to that have heard those kinds of things. So that's always in the back of their mind. And I think that you show a certain sensitivity to those kinds of things that we'd like to see more providers have to the psychosocial side of living with sickle cell, particularly as a patient gets older. So thank you for your compassion in that area. Let's say that I'm a sickle cell patient that's just moved here from out of state, I was referred to you for care. So I'm going to come see you for the first time. What are the first things you're going to do, and why?
And this is actually something that's fairly easy for me to talk about, because it does happen every so often. So usually the first thing I want to find out from a new patient with sickle cell who's from out of state is where they were receiving their sickle cell care before, and if they were under the care of a hematologist with a sickle cell program, or perhaps a hematologist who was in a private practice, or sometimes their doctor wasn't specifically trained in hematology, but perhaps was an internist who'd taken an interest, or had enough information to be able to care for somebody with sickle cell, or enough experience. Then I want to find out just more about the problems that they've had with the sickle cell. So we usually talk about, say, over the course of a 12-month period, how often would you find that you're admitted to the hospital, and what sort of complications? And then I might ask specifically if they know if they've had any particular complications, like if they ever had chest syndrome, for instance, or did they have a history of stroke, common things that can happen to somebody with sickle cell, and just get general medical history.
Okay.
And then I'll ask about some issues that have to do with health maintenance.
Okay.
Now, I know if somebody is coming from a sickle cell center, then it's quite likely that they will have had some routine health maintenance type of thing. So I'll ask about, have they had immunizations, hepatitis immunizations, pneumovax, so immunizations that we routinely give. Have they had an eye exam on a regular basis? How often do they see their provider? What sort of blood work have they had monitored? Have they been on hydroxyurea? Do they know about it? Have they been on treatment with it, and so on?
Okay. So after you've gathered my medical history, you're going to have an idea of some things that you might want to investigate further. So you might want to do some blood work on me. What might you want to look at?
So that would depend again on
some of my answers, right?
Yes.
Okay.
For example, I might want to start from scratch, and even get a hemoglobin electrophoresis to identify specifically what type of sickle cell we're dealing with, because people don't always know exactly what they have, and that makes a difference. And then usually I'll want, if there's been any history of transfusion, then I'll usually want to get blood tests for hepatitis. We'll often do a routine HIV screening test. I'll want to see if there's immunity to hepatitis. If not, we typically want to provide hepatitis A and B immunizations.
Okay.
Then I'll just want to look at simple blood tests that give me some idea of organ function for the kidneys, particularly liver. I'll ask the patient if they've ever had something called an echocardiogram, which is an ultrasound of the heart to show how well the heart is functioning. We'll often get a blood test, particularly in somebody who's had transfusions, to see whether they've got a buildup of iron in their system. That's a blood test called the ferritin level. And so usually at the first visit we'll address some of those issues. Now, we could be dealing with some practical things as well. For instance, if it's somebody who's come from another state, perhaps they've come because of a job change. But if it's somebody who's moved, for instance, to be closer to family, then maybe they don't have health insurance coverage right now. So then we need to start working on trying to put that into place.
Okay. So it sounds like it would be pretty thorough. Let's say I have sickle cell SC, and I know that, but I haven't been in a sickle cell program. I did have a internist who really was the one that took care of me the most, and I did have some interaction with a hematologist. Does that change how you're going to approach working with me?
It would. I think it would change some of the details.
Okay.
That we might look at. For example, somebody with SC sickle cell disease might be one of my concerns would be the eye exam for somebody with SC disease, because I think of them as being a little bit more susceptible to eye problems than somebody with SS sickle cell.
Interesting.
And another thing we would obviously talk about at the first visit is pain issues, and whether there have been pain issues, whether that person takes medication for pain on a frequent or regular basis, what they've been used to dealing with, and get some idea of the history of painful episodes and painful complications of sickle cell.
Okay. Ladies and gentlemen, Dr. Greist is providing us with a lot of information. I hope you're getting it all in. We're going to take a break. When we return, we'll continue our discussion and learn even more.
MAST Therapeutics is leading the way in developing treatments for sickle cell disease. We're proud to sponsor the Martin Center Sickle Cell Initiative in its mission to provide leadership, education, and support services to the sickle cell community.
Welcome back to the Sickle Cell Action Network Internet Radio Show. I'm Gary A. Gibson, your host, and I am speaking with Dr. Ann Greist, a adult hematologist, oncologist who treats people with sickle cell disease, and she's been sharing a lot of great information. I'm going to take her on a sidetrack right now, because one of the things I'd like you to know about this amazing person is that she also spends time in Kenya. The Indiana Hemophilia and Thrombosis Center for many years now goes to Kenya to help fight sickle cell there, and I'd like Dr. Greist, if she would, to give us a little bit of information about that and tell us a little bit about this whole experience of going to Kenya.
Well, I would love to talk about that just a little bit. A few years ago, there was a Kenyan physician who graduated from medical school who came to Indiana University Medical Center to do more training. And Indiana University started a remarkable program in Western Kenya for provision of health care to the patients in that part of the world. And they started out initially doing general medical care, and they subsequently, over a period of about a decade, made a huge impact on HIV care for people there. but one of their medical school graduates, as I mentioned, came to Indiana University and did a 3-year residency in internal medicine, and then went on to train in hematology oncology. And that young man's name is Dr. Chite Asira. While he was in Indianapolis, he came to spend a little time at the Indiana Hemophilia and Thrombosis Center. We got to know him, and he convinced us to collaborate with him when he went back to Kenya, because he was really hoping to make an impact on sickle cell care there.
Okay.
So sickle cell disease really comes from areas of the world where there is a lot of malaria, because people who are sickle cell carriers, who have sickle cell trait, are a bit more resistant to serious infections by the malaria parasite. And so if you look at areas of Kenya, true to this rule, as it were, in parts of the country where there's a lot of malaria, there is a lot of sickle cell disease.
Right.
And in western Kenya, there are some areas around Lake Victoria where there's a lot of malaria, and as many as 1 in 3 of the population may have sickle cell trait.
Right.
So the number of people with sickle cell disease could be very high, except for the fact that they typically are not diagnosed in infancy or childhood, and many infants die even before the age of 5 years of age from complications of sickle cell disease, usually from overwhelming infection. And so Dr. Asira had badly wanted to start a newborn screening program, which we've had here in the States since the 1980s, and wanted to be able to provide lifetime care to people with sickle cell of all ages. So that's definitely one of the main areas that we focused on over the past 6 years since we started going to Kenya to collaborate with Chite on a regular basis.
So you're going to leave on Friday, when? This coming Friday? No, sometime in April. Right?
This coming Friday, that's correct.
You will be gone for how long?
For 3 weeks.
For 3 weeks. And you're there to provide care?
So we do a lot of educating.
Okay.
We meet with our Kenyan colleagues. So there's a hematology team there of doctors, nurses, and clinical officers who are like who would be the same as physician assistants here, who are in their hematology oncology program and are working with the sickle cell patients. So they have a sickle cell clinic, and we usually work with them in the sickle cell clinic. We usually do some conferences for healthcare providers, and we have started a newborn screening program, and we usually have several meetings about the ups and downs of the program, equipment problems that they've had, getting families to have the testing done, and then getting them back into clinic and providing them with the basics of the care that they need, and then trying to expand the screening program to different hospitals in the region.
Okay. Which is still very, very important, because screening is still not something that happens like it should in that part of the world, right?
That's correct. It's practically
non-existent, correct. Yes. Okay, and that's why I've raised the issue that I have before, that one of the concerns that I have, Dr. Greist, is that everywhere pretty much in the United States is seeing increases in immigration. And that many of the immigrants come from places where they don't screen, where sickle cell is prevalent. And this is something that we're working on here at Martin Center Sickle Cell Initiative, to try to find a solution to be able to provide free trait screening to people that come from areas that may be affected, so that they will at least know what their sickle status is.
I think that's terrific, and I agree with you. I'm sure it's a growing need.
I believe it's a growing need, definitely. When you look at the statistics and you see the immigration trends, I think it's something we ought to be concerned about. Getting information from patients is definitely critical when it comes to treating them with any illness, but because of its nature, it might be even more important when the patient has sickle cell disease. Would you explain how getting good information from them helps you do your job better? We kind of talked about if I was coming to you from out of state and I was my first visit with you and you started asking me these questions to get my medical history. So if my medical knowledge isn't all that good and if I'm not really forthcoming with a lot of information, how does that affect your ability to treat me?
I think it probably impacts. I think it makes it a little more likely that we might overlook things that are important, and that we would not immediately be aware if there was an issue that needed to be addressed pretty promptly. And it might possibly mean that we would be a bit more likely to introduce treatment that could perhaps have more complications. So with things that we really want to know when somebody comes to us for the first time, particularly from a different state, are things that we want to have established for all of our patients. Really, we want to know what a person's typical hemoglobin level is when they are well and not acutely ill. So, if somebody typically has a hemoglobin of around 9 or 10 grams, and they come to the emergency room with a hemoglobin of 6 or 7, we immediately know that there's been some drastic change. We definitely want to know what type of sickle cells specifically a person has, and I often do find that new patients aren't terribly sure if they have SS or if they have sickle thalassemia or SC, which are the main types. And I mentioned one example of that would be somebody with SC sickle cell might be more likely to have some eye problems than somebody with SS sickle cell. People with SC as adults can occasionally even have what we call a splenic crisis, whereas really that's never even heard of in an SS patient. So things like immunization status, what type of sickle cell, what the baseline hemoglobin level is, a transfusion history, those sorts of things.
Can we go back to that baseline hemoglobin, because I want to try to have you help me dispel, I think, what is possibly a myth. I recently heard of a patient that went to emergency and was told that, no, you can't really be in crisis because your hemoglobin level's still good. Is that true? I mean, it can happen that way, can't it?
Definitely.
Yeah.
Definitely. I think I have some patients where during a crisis and say an inpatient stay, that particular patient will typically have a decrease in their hemoglobin level during the course of the crisis, and usually as they start to get better, the hemoglobin level stabilizes and then may start to go up again. For that one individual patient, I may know that is their typical pattern. But you cannot apply that as a generalization to everybody, and so you cannot look at the hemoglobin level and be able to determine whether somebody really is having an acute vaso-occlusive episode or not.
Yeah, that's what I wanted you to say, because sometimes people have encountered that when they present themselves to emergency departments where maybe there's not a lot of familiarity with treating people with sickle cell, and they'll do the test and they'll come back and say, oh yeah, but your hemoglobin's 8. You can't be having a bad crisis. Yes, I am, and then you start that battle back and forth of whether or not the hospital staff believes them, and that leads to other issues sometimes. So what does your experience tell you about how sickle cell manifests itself as people get older? We talked a little bit earlier about the difference between pediatrics and adults, but as people progress through their adulthood, do you see changes? So if, somebody's 25 or 30 versus one of your patients that's maybe 50 or 60, do you see any differences there?
I think the biggest difference we might see is the situation that I mentioned a little earlier, where we're starting to deal with the cumulative effects of somebody having to live with sickle cell all their lives, and I think that that becomes more of an issue as they get older. There's just more wear and tear on organs, and less organ resilience. So we can see problems with impaired function of the kidneys, impaired function of the liver, the lungs. Somebody who's older may consistently need to be on oxygen supplementation when they come into the hospital, for instance, whereas perhaps 20 years ago they didn't need it when they came to the hospital. So those sorts of things. And then we also start to see health issues that can come into play, which are things that anybody could have as they get older, not necessarily somebody with sickle cell.
Mm-hmm.
And so as somebody with sickle cell could develop a heart problem, like an irregular heart rhythm, which could be typical for a person of their age and is not necessarily directly related to their sickle cell. So we start to see health issues that are more common in the older population, whether or not they have sickle cell, that complicate the sickle cell.
Right. Well, my wife that passed away at the age of 36 died because of a massive heart attack. She lived for several years with an enlarged heart at age 36. And granted, it was before there was opportunities to have her on hydroxyurea and things like that might have helped. But that is something that I'm always concerned about, and it's one of those things that you want to ensure, if you are an adult sickle cell patient, that you are seeing all of these different specialists or working in a managed care fashion. I generally try to give you an idea of what kind of things we're going to talk about, but this is one I didn't, and it's just coming to mind now. Please tell people how important it is for them to ensure that they have managed care that's looking after every part of their body. I mean, in other words, make sure that your heart is functioning well, make sure your kidneys are functioning well. You've kind of touched on these things, but isn't it something we really need to stress?
Yes.
Yeah.
Yes, I absolutely agree.
Okay. One of the hot topics in sickle cell field is that of effective transitioning for patients as they go from pediatric to adult care. Do you play a role in that process?
I think we definitely have a role to play. We meaning the providers for the adult patients.
Mm-hmm.
I think the pediatric team is doing a terrific job of transition care, beginning to prepare teenagers for their healthcare needs as adults.
Mm-hmm.
They're developing a lot of tools. They're really taking an interest in the teens and sometimes even the preteens. But I think there's a lot of work to be done in the adult arena as well, because I think it's a very hard transition.
Mm-hmm.
And I think even up to the mid-20s, maybe even a little beyond that, young adults are still trying to figure out who they are and where they're going, regardless of whether they have
Right.
a disorder like sickle cell to
Right.
deal with as well. So you add sickle cell even the normal stresses that a young adult experiences, and I think it can just be overwhelming. So I think as adult providers, we can do a lot to try and smooth that transition, and prepare young adults for the challenges that they're going to experience, but perhaps not be surprised when things collapse a bit, and just be ready to pick them back up and and keep them going too.
Right. Okay, ladies and gentlemen, you're listening to Dr. Ann Greist, a very experienced, very knowledgeable, very compassionate provider. We are going to take one last break, and when we come back, we'll finish the show. We'll have a few more questions for Dr. Greist, but that's in a few minutes. This is the Sickle Cell Action Network Internet Radio Show. I'm Gary A. Gibson, your host, and we'll be right back. Welcome back to the Sickle Cell Action Network. This is Gary A. Gibson, your host. The Sickle Cell Action Network is brought to you as a service of Martin Center Sickle Cell Initiative. Martin Center Sickle Cell Initiative is a 46-year-old agency that provides services to people that have sickle cell disease. We also provide education within the community, and we do a lot of advocacy. The Sickle Cell Action Network is a branch of our advocacy efforts, and we are reaching all around the globe with information about sickle cell disease. We're glad you could be with us, and we are speaking with Dr. Ann Greist. Dr. Greist, you've been caring for people with sickle cell disease for a while, and what would you say are the top 3 issues with regards to how it impacts people? And you can go physical, or you can go psychosocial, whichever direction you want to go, or you can blend them. What are the top 3 issues in your mind, or the top 3 impacts?
Well, I certainly think that one of the top 3 impacts is I think there's a tremendous psychosocial impact, and particularly one of the things I think we're learning more about that I haven't mentioned up until now, as it affects adults with sickle cell, is we're really starting to realize more that our adults now may often have had, as a consequence of their sickle cell, without anybody realizing it, small silent strokes.
I've heard this.
As children. And that once they reach adulthood, this can have a tremendous impact on psychosocial aspects in all sorts of ways. And it may impact their understanding of their disorder, how medications affect them, being able to get education, being able to have jobs, their relationships with other people. I think that's a very important area that's been under recognized in the past. And I think it has quite a bit to do with some of the negative attitude in the healthcare system that sickle cell patients sometimes come up against, because people don't realize that. Healthcare providers don't realize that they might explain something to somebody with sickle cell, or they completely miss the boat on how much they understand. Or a patient with sickle cell may react to medication in a certain way that may have a very sort of negative impact on the healthcare provider, and that, of course, impacts the care that person may receive. So that's certainly an example of something that's very important in the psychosocial area. And definitely the physical consequences of sickle cell are tremendously impactful, and the burden of just dealing with the complications over the decades, that's certainly something that's that is at the forefront of what a person with sickle cell experiences.
Thank you. So as a follow-up to that, what are the top 3 things that give you hope for being able to provide continuously improving care for your patients in the future?
Well, I think there are some, I think in the immediate future, I think there are some very exciting things going on with hydroxyurea at the moment. And because of the beneficial effects of hydroxyurea on the course of sickle cell disease, pediatricians are becoming more and more experienced in starting hydroxyurea for young children.
Mm-hmm.
And seeing that the benefits of hydroxyurea have a positive impact on the health of children as they get older. So I'm sort of excited to see that there is a possibility of a generation of young adults coming along who may have had the opportunity to take hydroxyurea and may be healthier overall than the adults we've taken care of in the past.
So by the time they see you, they're going to be in better shape than some of the patients you see now.
I think so.
Yeah.
I think so, yes. In the future, a little bit further on, I also think that there are some very exciting scientific advances being made in research, that the better understanding of what's actually going on in the body during a sickle cell crisis, or even on a day-to-day basis as the blood cells circulate through the bloodstream. I think that is providing targets for other medications that could be beneficial in the management of sickle cell.
Basically understanding some of that chemistry you were talking about earlier, right?
Exactly.
Okay.
Exactly. And then the prospect of some advances, real advances, in the area of gene therapy, too.
Okay.
I think we might be on the verge of some real breakthroughs.
It does seem like it, and we hope that the research in that area ends up being as promising as it seems to be today, and certainly we're going to be following that, and we do hope to actually have a future show basically entirely devoted to gene editing and that whole thing. So it's time for me to ask you this very, very important question. As a provider, what advice would you give our listeners that are adults with sickle cell?
I think the advice I'd like to give to adults with sickle cell is wherever you are, try and connect yourself with a physician or a healthcare provider, not necessarily a hematologist, but somebody you can have a good and trusting relationship with. If they aren't trained in hematology or care of sickle cell, hopefully you can find somebody who's a good listener, who's ready to be educated. And I think the most important thing for somebody as an adult with sickle cell, and this can be a hard thing to do, is to have regular follow-up visits. So even when you're not sick, and even when you don't need to go to the hospital acutely, I think those regular follow-up visits are extremely important. There are really good guidelines that are on the internet that any physician can access very easily, that can just give them the ABCs of health maintenance for an adult with sickle cell disease. And I think if they can see you on a regular basis, and see that you are committed to fighting for the best health that you can achieve, they're going to be in your corner, and they're going to really want to do things to watch out for your organs and to maintain your health.
Very well said and very informative. Thank you so much, Dr. Greist. I guess I did have one additional question. Do you help your patients by providing them information on nutrition?
A slightly broader answer to that question is that in our practice, we're very much focusing on what I mentioned earlier is multidisciplinary care.
Mm-hmm.
We're interested possibly in some complementary therapies.
Okay.
And nutrition would certainly be a part of that.
Okay.
And we're very fortunate, I think, in our practice to have the possibility of other disciplines
Right.
who might be able to play a role. And I would say nutrition is definitely one of those things.
Thank you very much. Do you have anything else you'd like to add for today?
I would just like to thank Gary again for inviting me to be on this program and have the opportunity to talk to him and all of you about sickle cell disease.
Delighted to have you. Very good show. Thank you so much for being here. We are going to close out our show, and as always, do that with leaving you something to think about. And I usually start with a quote, and this time I'm going to use a quote from Margaret Mead. "Never believe that a few caring people can't change the world, for indeed that's all who ever have." Margaret Mead was an American cultural anthropologist who featured frequently as an author and speaker in the mass media during the 1960s and 1970s. She earned her bachelor's degree at Barnard College in New York City and her MA and PhD degrees from Columbia University. She was a respected and often controversial academic who popularized the insights of anthropology in modern American and Western culture. You know, this is a very exciting time in the world of sickle cell disease. A quick look over the sickle cell landscape will reveal that there is more positive energy and activity than ever before. This is tremendously exciting and hopeful for everyone involved, whether they be patients, caregivers, or organizations like Martin Center Sickle Cell Initiative and the Indiana Hemothrombosis Center. We are all excited because we see so many signs of hope that those who suffer from this challenging disorder will one day find relief in the form of better medical treatment, better educational and employment opportunities, and yes, even a cure. The driver for these advances that we are witnessing these days is that more and more people are caring about sickle cell. For instance, more people now care about how sickle cell affects patients and their families. More people care about how sickle cell works, and they care about finding ways to outsmart it and get rid of it. And more people now care about providing more support to relieve the suffering caused by sickle cell's psychosocial pains. All of these things represent a drastic change over years gone by, and they validate the fact that our world cares more about making a difference than it ever has before. But one thing hasn't changed: the compassion that is demonstrated on a daily basis by those people whose lives are devoted to caring for sickle cell patients. They are the caregivers. Sometimes they are family members, sometimes they are friends, and sometimes they are dedicated medical professionals. All of them are making a positive difference in the lives of those they care for. Just imagine what life would be like for any patient who had no one to care for them. That's not a comforting thought, now is it? Without caregivers, many patients would have no food to eat, no clothes to wear, no way to get to medical appointments, and no one to listen to help them sort out their problems. Without caregivers, their life might be empty and quite possibly even hopeless. Without caregivers, many patients alive today might have already passed away. That's why it is so important for us to acknowledge the very important role that caregivers play. Caregivers enrich life, and they extend it. If you are a sickle cell patient, please make sure that your caregivers know how much they mean to you. If you are a caregiver, please understand that even if it isn't regularly acknowledged, your caring dedication is more valuable than you may know. Your devotion changes lives, and it saves them too. Sickle cell disease is a wicked disorder, and the way that it has been handled by society in past years is contemptible. It is the most common of humanity's genetic disorders, and it is nothing less than appalling that it still exists. But all of this is changing, slowly but surely. It is changing because more and more people care. I think that the caring people in the sickle cell community are proving that Margaret Mead was right when she said, "Never believe that a few caring people can't change the world." I hope you agree, and I hope that you keep caring too. That's our show for today.